We often talk about the big health topics, the ones everyone knows, but sometimes it's the less common conditions that really need a closer look.
Absolutely. Understanding the full picture is so important for your health.
So today we're doing a deep dive into one of those topics, penile cancer. Maybe not something you think about daily, but definitely crucial to understand.
Exactly. Think of this as your high-yield revision session. We've gathered the key info from various sources, aiming for clarity.
Our mission, to give you a solid grasp definition, causes, risks, diagnosis, management, the whole package, really.
All presented in a way that hopefully sticks, making it easier for you to recall later.
Okay, let's get started. In simple terms, what is penile cancer?
Well, essentially, it's a malignant growth. Abnormal cells start multiplying uncontrollably in the tissues of the penis.
And it usually starts in the skin.
That's right. Most often it begins right there in the skin cells. And the critical thing is catching it early.
Because it can spread otherwise.
Precisely. Like any cancer, if it's not addressed, it has the potential to spread to other parts of the body.
And you mentioned a specific type is most common.
Yes. For revision, remember this. About 95% are squamous cell carcinomas. They come from the flat surface cells of the skin.
Got it. So what causes it? Is there a clear culprit?
It's not quite that simple. There isn't one single cause we can point to, but rather a collection of factors that seem to contribute.
Like pieces of a puzzle?
Kind of, yeah. A really significant piece is infection with certain high-risk strains of HPV, the human papillomavirus.
Okay, HPV is a big one. What else?
Poor genital hygiene is another factor. It can lead to chronic inflammation, which isn't good. Then there's phimosis.
That's the tight foreskin issue, right?
Exactly. Where the foreskin can't be easily retracted, that's linked to increased risk.
And lifestyle. Does that play a part?
It definitely can. Tobacco smoking is a known contributor. And also anything that weakens the immune system, like a immunodeficiency condition.
So those are the potential triggers, the etiology. What about the specific risk factors? Things that make someone more susceptible?
Right, there's some overlap here, but it helps to list them out. Phimosis and poor hygiene are definitely on this list, too.
And HPV again?
Yes, HPV is crucial, particularly those high-risk types like HPV-16 and HPV-18. Smoking, as we mentioned, is a significant risk factor.
What about age?
Age is a big one. It's most common in men over 50, although younger men can get it, too.
Anything else?
Uh-huh. A history of genital warts or other STIs increases risk. HIV infection does, too. Also, PUVA treatment, which is sometimes used for psoriasis.
PUVA treatment, interesting.
Yeah. And even things like minor penile injuries, tears or abrasions, and possibly exposure to certain chemicals.
Oh.
Things like insecticides, fertilizers, even styrene and acrylonitrile have been mentioned in studies.
Okay, that's a comprehensive list. Now,
Yeah.
how does it actually develop the pathophysiology?
It often doesn't just appear as full-blown cancer. It might start as precancerous lesions.
Precancerous, like
Yeah.
warning signs.
Exactly. Two names to remember are Bowen's disease and erythroplasia of Queyrat. These are changes in the cells that aren't cancer yet, but they can progress to invasive cancer over time.
And HPV's role here.
High-risk HPV seems to play a really important part in that progression, though the exact mechanisms aren't, well, fully mapped out yet.
And if it does become invasive?
Then it can start invading nearby tissues. It might grow into the urethra or the corpora cavernosa, that's the spongy erectile tissue.
And spread further.
Yes, that's the danger. It can spread locally, then to the lymph nodes, usually starting in the groin, and potentially travel to distant organs.
It sounds like it could be mistaken for other things initially. What are the differential diagnoses we need to consider?
Good point.
Yeah.
You definitely need to rule out other conditions. Genital warts, for instance, can look similar sometimes.
What else? Skin conditions.
Yes, other non-cancerous skin issues like balanitis, that's inflammation of the glands, or lichen planus.
STIs, too.
Absolutely. Things like herpes or syphilis can cause sores or lesions. Even benign bumps like sebaceous cysts could cause confusion.
And very rarely could it be cancer spread from somewhere else.
It's uncommon, but yes, metastatic cancer, say from the skin elsewhere, could potentially present on the penis. So careful diagnosis is key.
Let's talk numbers. How common is this, really? The epidemiology.
Well, as we said, squamous cell carcinoma makes up the vast majority, around 95%. But overall, primary penile cancer is actually quite rare in Western countries.
How rare?
In Europe, for example, the incidence is less than one case per 100,000 males per year.
And in the UK?
In the UK, it accounts for less than 1% of all cancers in men. Most cases are diagnosed in men in their 60s, but it's important to remember about 25%, a quarter, occur in men under 50.
Is it more common elsewhere?
Yes, significantly so in some non-Western regions. In parts of Africa, Asia, and South America, it can represent 10 to 20% of male cancers.
Wow, that's a huge difference. Any idea why?
It's complex, but factors like hygiene practices and HPV prevalence likely play a role. And there's a really interesting point about circumcision.
Ah, yes, you mentioned that earlier.
Right. Being circumcised early in life, typically in infancy, seems to offer significant protection. The risk is about 3 to 5 times lower.
But not adult circumcision?
Apparently not. Adult circumcision doesn't seem to confer the same protective benefit against penile cancer.
So higher rates in older men, generally over 65 in the UK, geographical variations linked perhaps to hygiene and HPV, that gives us a good sense of the landscape.
It does. It highlights where the risks might be higher.
Okay, so what should someone actually look out for? What are the clinical features, the signs and symptoms?
The most common things people notice initially are maybe a lump or a growth on the penis or perhaps an ulcer, like a sore that just won't heal.
Any other changes?
Yes, changes in the skin itself, maybe thickening or a change in color, sometimes bleeding or an unusual discharge can occur.
Where do these usually appear?
Often, they start on the glands, the head of the penis, or on the foreskin, the prepuce. Some men might also feel itching or burning.
And if it's left untreated?
Well, unfortunately, neglected tumors can become quite destructive. They can damage the glands and foreskin and invade deeper into the shaft of the penis.
And the spread?
We talked about lymphatic spread. That often goes to the inguinal lymph nodes in the groin and potentially the pelvic nodes. And of course, distant metastasis is possible in advanced stages.
How often are the lymph nodes involved at diagnosis?
It's estimated that about 20% of patients, so 1 in 5, will already have palpable inguinal lymph nodes you can feel when they're first diagnosed, which often signals that the cancer has started to spread.
So persistent lumps, ulcers, skin changes, discharge, bleeding. These are all red flags.
Definitely. Anything unusual or persistent warrants getting checked out by a doctor?
So someone presents with these signs. What happens next? How is it investigated and staged?
The absolute cornerstone for diagnosis is a biopsy. You have to get a tissue sample.
To confirm it's actually cancer.
Exactly. And to see what type it is, that sample is examined under a microscope.
And then to see how far it's gone. Staging.
Right. For local staging, how far it's spread within the penis, imaging, like MRI or sometimes ultrasound, can be helpful.
What about the lymph nodes?
Assessing the lymph nodes is crucial. It involves a clinical examination, feeling the groin area, but also imaging, like CT scans or MRI scans.
And sometimes a specific biopsy.
Yes, a sentinel lymph node biopsy might be done. This procedure identifies and removes the first lymph node or nodes that cancer cells would likely spread to. It helps determine if the cancer has reached the lymphatic system.
Then comes the formal staging.
Correct. We use the TNM system. It's standard for most cancers. T stands for the primary tumor size and extent.
Can you break that down?
Sure. T0 means no evidence of a primary tumor. TIS, or carcinoma in situ, means it's pre-invasive, just on the surface. T1 means it's invaded the connective tissue just under the skin. T2 means it's gone into the spongy erectile tissue, the corpora. T3 means it's invaded the urethra. And T4 means it's invaded adjacent structures, like the prostate or scrotum.
Okay, that's T. What about N?
N is for regional lymph nodes. N0 means no spread to nearby lymph nodes. N1 means spread to a single inguinal lymph node. N2 means spread to multiple inguinal nodes or nodes on both sides. N3 means spread to the deeper pelvic lymph nodes or ulceration of a node.
And M.
M is for metastasis, distant spread. N0 means no distant spread found. M1 means the cancer has spread to distant organs, like the lungs, liver, or bones.
That system gives a very clear picture of how advanced the cancer is.
It does, and that staging is absolutely critical for deciding on the best course of treatment.
Right, let's talk about management then. What are the main treatment options?
It really depends heavily on that stage we just discussed, and also the patient's overall health. Surgery is often a key component.
What kind of surgery?
For very small, superficial lesions, it might be something like circumcision if it's on the foreskin, or a simple excision, just cutting out the cancerous area. Sometimes ablative techniques like laser therapy or cryotherapy are used.
And for slightly larger tumors?
For tumors confined to the glands or the end of the penis, surgeons often perform a partial penectomy. The aim is always to remove the cancer completely, but ideally preserve as much of the penis and its function as possible.
Are there non-surgical options, like radiotherapy?
Yes, radiotherapy can be an option, especially for smaller lesions or for patients who aren't suitable candidates for surgery. It can be delivered via external beam radiation or sometimes brachytherapy, where radioactive sources are placed directly into or near the tumor.
Does radiotherapy help with lymph node spread?
Its role in managing regional lymph node metastases is still somewhat debated and being researched. Surgery, the lymphadenectomy, is more standard there.
What about chemotherapy?
Chemotherapy generally has a more limited role in penile cancer compared to some other cancers. The response rates aren't always high.
When is it used then?
It's typically used in more advanced cases. Cisplatin-based drug combinations are common. Sometimes it's given before surgery or radiotherapy. That's called neoadjuvant chemo to try and shrink the tumor first. Or it's used for metastatic disease that has spread widely.
Are there specific chemo regimens?
Yes, combinations like cisplatin with 5-chlorophyll, 5-FU, or irinotecan are often used. If someone can't tolerate cisplatin, there are alternative options.
So the overall approach seems very tailored.
Absolutely. For early superficial tumors, the focus is often on penile-preserving strategies. If the inguinal lymph nodes are involved, removing them surgically, the lymphadenectomy is usually recommended.
What if the cancer comes back after a more conservative penis-sparing surgery?
Interestingly, studies suggest that recurrence after conservative surgery doesn't necessarily negatively impact overall survival, provided it's detected and managed promptly.
And for very advanced metastatic disease?
In that situation, the focus often shifts towards palliative care, managing symptoms, controlling pain, and maintaining the best possible quality of life.
You also mentioned premalignant disease earlier, like Bowen's disease. How is that managed?
Right. For those precancerous lesions, the goal is complete removal. Often, an excisional biopsy does the trick. Circumcision might be recommended too, followed by close monitoring.
Are there other treatments for precancerous stuff?
Yes. After an initial biopsy confirms it, topical treatments can be used. Things like topical chemotherapy with 5% 5-fluorouracil cream or topical immunotherapy with 5% amikmod cream.
Like applying a cream directly?
Exactly. And for cases that are resistant or very widespread, lasers like the potassium titanyl phosphate KTP laser might be used.
So a whole range of options depending on the exact situation.
Definitely. It's very much about stage, location, and individual patient factors.
What about the long-term outlook, the prognosis?
Well, the overall 5-year survival rate is often quoted as being around 50%, but that's a broad average.
Has it improved over time?
Yes, significantly. Treatment has definitely advanced. While cure rates were maybe around 50% back in the 1990s, recent data suggests they're closer to 80% now, especially when caught earlier.
That's encouraging, but it must still have a big impact.
Oh, absolutely. We have to acknowledge the psychological impact, which can be huge, and potential physical consequences, too, which can sometimes be, well, quite mutilating depending on the treatment needed.
Which brings us back to prevention, perhaps.
Yes, prevention is key. We talked about early circumcision reducing risk. Preventing phimosis and treating chronic inflammation promptly is important. Lifestyle choices matter. Quitting smoking is a big one.
And safer sex.
Definitely. Using condoms helps reduce the risk of HPV transmission. Understanding HPV risks and potential vaccination is relevant too. And crucially, encouraging early reporting of any symptoms.
Even if it feels embarrassing.
Especially then, overcoming that potential embarrassment to get checked early can make a massive difference to the outcome.
What are the potential complications, either from the cancer or the treatment itself?
Several things. The cancer can spread locally, invading nearby tissues and organs. Lymph node involvement and distant metastasis are major complications.
Functional issues, too?
Yes, both the cancer growth and treatments like surgery or radiotherapy can potentially impair urinary function and sexual function.
And the psychological side.
We touched on it, but it bears repeating. The psychological and emotional impact of diagnosis and treatment can be profound and requires support.
Okay, this has been incredibly thorough. If we were to summarize the absolute key takeaways for someone revising this topic, what would they be?
Right, key points.
Yeah.
First, definition. Malignant growth, usually squamous cells starting in penis tissues. Second, etiology. Multifactorial, but think HPV, poor hygiene, phimosis, smoking.
Risk factors.
Similar list. Plus age over 50. History of STIs warts, HIV, PUVA, pathophysiology. Often starts as precancerous lesions, HPV involved, potential for local invasion and spread via lymphatics and blood.
Differentials.
Need to rule out warts, benign skin conditions like balanitis, STIs like herpes syphilis, benign cysts, rarely metastasis. Epidemiology. Rare in West, commoner elsewhere, early circumcision protective.
Clinical features.
Penile lump, ulcer, skin change, bleeding, discharge are key signs. Watch for groin nodes. Investigations. Biopsy is essential for diagnosis. Imaging, MRI, CT, and sentinel node biopsy for staging using TNM. Management. Highly dependent on stage. Surgery, from excision to penectomy, radiotherapy, sometimes chemotherapy, cisplatin-based. Focus on penile preservation when possible. Premalignant treated with excision, topicals, or laser.
And finally, prognosis and complications.
Prognosis. Around 50% 5-year survival overall, but improving. Cure rates now near 80%. Significant psychological impact. Complications include spread, metastasis, urinary sexual dysfunction, emotional distress. And remember prevention. Hygiene, smoking cessation, safe sex, early reporting.
That really pulls it all together. A fantastic framework for understanding penile cancer.
Hopefully that provides a clear, digestible overview for revision purposes.
Absolutely. And for those of you listening who want to explore more medical topics or need resources for your studies, do check out pathomsra.com.
And also freemsra.com for additional materials.
Great resources. It's clear that ongoing research and awareness are vital for improving outcomes in conditions like this.
Couldn't agree more. Continuous learning and early detection remain our best tools.